wanted to show this to you. We showed you that slide early on with a picture of the globe and talked about growing numbers of older people all over the world. The World Health Organization has awakened to the issue of dementia. And last year, in 2012, they published this lengthy report called Dementia, a Public Health Priority. So what the World Health Organization is trying to do is to rally countries all over the world to pay attention. And they've got lots of interesting data in this book about, they divided into high-income, middle-income, and low-income countries and talk about the different kinds of challenges these countries face. So dementia doesn't discriminate whether you're in Africa or China or Australia or California. Lots of people worldwide, 35.6 million people have it, and the number will double every 20 years. These changing patterns in low and middle income countries mean fewer family care partners, and this is very much a concern in countries like China, for example. You've read about how young people are flocking to the cities for work, and the old people are left back in the rural villages. Well, that's exactly what's happening in Wisconsin, in all our northern counties, where that dark blue was in the map that John showed you. So it's not just an issue for countries like China or India, but it's an issue for us as well, because when there are no jobs, the young will leave. Policy, and this is again from this World Health Organization publication. I think this is a very important statement, that policymakers need to pay attention to health and social care needs, including for care partners. Okay, so that's huge. It's not just that the World Health Organization is saying we need to test people and give them a pill, but we need to pay attention to the social care needs. And that's going to be a big theme for our discussion today. So what can we do in our communities to embrace persons who have dementia and their care partners? And we need to encourage the development of dementia-friendly communities globally. And that's another theme that you'll see in more detail this afternoon. Excuse me. This is a recent publication. As John said, these prevalence figures are hard to pin down, but this is a good one that shows the projected number of people age 65 and older with clinically diagnosable probable Alzheimer's disease from 2000 through 2050. So the total goes up here to 11% of all persons 65 and older, 38 to 40% of all people 85 and older, 44%, that's almost half of everybody between age 75 and 84 has Alzheimer's disease. And then 13% of persons aged 65 to 74. And I'll tell you the shocking figure that I don't have on this slide, but that I recently calculated, just for our county in Wisconsin. Okay, so I went to the 2010 demographics, and you can do this too for wherever you live, whether it's a city or a county, and figure out how many people, according to the 2010 census, are 65 or younger in your county. Okay, and then take 4% of that group, because it is currently estimated that 4% of people 65 and younger have Alzheimer's or other form of dementia. And in our county, Outagamie County in Wisconsin, that was 6,000 people in one county. Okay. So, we've got a big challenge here, but we are not going to tell the story in terms of the language of fear. We're not going to do that. We're going to tell a different story. I don't know how much you know. Some of you know a lot. Some of you might know a little bit. I put this slide in here to demonstrate a couple of things to you. First of all, everything you thought you knew about the language we use to describe dementia is going to change in May. Because that's when the American Psychiatric Association is going to release the new Diagnostic and Statistical Manual, DSM-5, okay? So, we are no longer going to use the word dementia. It is going to be neurocognitive disorder. And I would bet within 5 years we're all talking about NCDs, right? NCDs. The word dementia is going to disappear. And we're going to talk about neurocognitive disorders. And the DSM is going to split these neurocognitive disorders into two kinds. You're going to have the minor and the major. Now that's going to be really interesting in terms of, you know, well, I've got minor Alzheimer's disease, you know. I get to sit at this table, and I've got major, and I have to sit at that table. You know, this is going to be really interesting, and I don't know how it's all going to play out. The reason why I put the big red arrow, NCD, due to Alzheimer's is because that's the most common form of neurocognitive disorder. But there's lots of other ones as well, and not only that, but you can have mixed dementias. That means you don't have to have just one, you can have several. There are subtypes. So there's not just one frontotemporal neurocognitive disorder, there are several under that. John and I had a really poignant encounter. This is for all of you who work with folks with multiple diagnoses of dementia. This poignant encounter that we had a month ago at a big meeting that was sponsored by the Minnesota North Dakota Alzheimer's Association and Mayo Clinic. There were 1,300 people there. And many of them were people with a diagnosis. It's a big conference called Meeting of the Minds, and it's put on for people who have the diagnosis and care partners. So the first couple of plenary sessions in the morning were all about, as John was describing before, these upstream diagnoses. I'm going to show you a slide in a little while that'll just give you more detail about this. The hope for a potential vaccine that might stop the course of change in the brain of these various proteins that change. So it was all about the Alzheimer's research. So, okay, plenary session's over. John and I go in to do our session. There's about, I don't know, 100, 150 people there. And we're talking about friendship, as we're going to get into that topic in more detail with you today. And afterwards, a couple came up to us, and they said, you know, thank you, especially for this slide. She's been diagnosed with corticobasal dementia, okay? It's a form of frontotemporal. It's relatively rare. And so her gait is off, her coordination is off, she's having various kinds of personality changes, etc. And she and her husband said, we wondered if maybe we should leave this morning because I don't have Alzheimer's disease. Am I welcome here? Do you hear what's going on? So I think increasingly you're going to be working with people who have been given the diagnosis of Lewy body dementia, okay? Or frontotemporal, or maybe some of you know somebody with Huntington's. And if all we talk about is Alzheimer's disease, then those people have to, you know, feel like they're being shunted aside. When in fact, remember the slide that John showed you earlier. If we still use this word dementia, you know, it's a progressive condition, and it can have many forms and many causes and many types. So here's my three-legged stool of research, practice, and policy. Okay, and most of you are in this area. You're in the practice area, right? But you all know, certainly those of you who work in long-term care, you know you have to pay attention to policy because decisions that are made in Sacramento and in Washington very much affect the way you work, right? And the care you give to your residents. We need this research piece. You know, we walk this fine line in terms of the Alzheimer's Association. They have put money into research, and you know, it's going to good causes, and good researchers are getting these grants. I have no argument with that. It's just that we're having such trouble getting care to people right now who have the diagnosis. We have a chapter of our Alzheimer's disease in Wisconsin. It's called the Greater Wisconsin Chapter of the Alzheimer's disease. It covers Alzheimer's Association. It covers 53 counties in Wisconsin. And they have a staff of, I think they've got 8 full-time employees to cover 53. How on earth can you possibly run these support groups and answer people's questions? And they do their best, but yeah, so the practice and the research sometimes are in contention with each other, and then there's this policy piece hanging out here. And a lot of this has to do with biomedical research, practice, and policy. And that biomedical approach is going to focus primarily on prevention, treatment, and cure. But it's the biopsychosocial research, practice, and policy that is going to pull in that piece of how do you live well with dementia. So do you see the differences here? Now, certainly the biopsychosocial also is looking at, you know, prevention, exercise, diet, social engagement, spiritual journeys, etc. Yes, it's looking at prevention, treatment. I don't know about cure, but maybe. But it is also taking into account how can we live with this and how can we live well. Whether we're living at home with a care partner, living at home alone, and we're getting people coming into the home, whether we're living in congregate housing, long-term care, etc. How do we live well with this? So, this is a very messy-looking slide, as Nancy said, you'll get copies of all these. It's from a publication from the National Institute on Aging, and what it is showing, this is time on the x-axis, normal to abnormal on the y-axis. And it's showing that there's a lot going on in the pre-symptomatic time. I can't emphasize this enough to you. What John said in terms of what we heard that guy tell us, that this may be called a disease of middle age. I stand in front of classes of students and I say, I could have Alzheimer's disease. And they look at me and they, you're my teacher. Okay? But I could. And this is what we're learning so much more about. And there are now a number of ways of seeing whether the characteristic changes are taking place in the brain before the symptoms show up. Okay? So CSF means cerebral spinal fluid, amyloid imaging, it's kind of brain imaging, PET scans that shows how glucose is being metabolized in the brain, MRIs to see, has your hippocampus shrunk? The hippocampus is the part of the brain for short-term memory. And you can see that as you move along, early mild cognitive impairment, late mild cognitive impairment, more and more of these biomarkers can be tested. Now, let's just pause for a moment here. Somebody mentioned suicide. You can now spend about $2,500. It's not covered by insurance. And there's a very fancy brain imaging machine that can be used to tell with pretty good certainty of whether you, a pre-symptomatic person, have Alzheimer's disease. So, ethicists and theologians and pastors in the audience, please think about this. The implications of this. First of all, who's going to be able to afford to get these tests? Right? It's not covered by insurance, let alone by Medicare. And then what are people going to do when they're told, that yes, you have got an accumulation of amyloid in your cerebral spinal fluid that within, we're 80% certain that means that these plaques are starting to build up in your brain. You see where we are and why we need thoughtful people in our society who are not just in the biomedical field, but who are thinking about psychological issues and social and spiritual issues. You see why we need to be having conversations about this? All of us together? There are some very big questions that need to be addressed. And the doctors are not going to be the ones who are addressing those questions. All right, I'm going to take you through just a couple of slides of research, okay? This is a study that came out in 2010 on non-pharmacological therapies, okay? So we know that there are a couple of pills. You all know about Aricept. You all know about Namenda. There are various kinds of medications that may slow the course of Alzheimer's disease in some people for a little while. It's not exactly, like taking an antibiotic when you have an infection, right? So what else do we have? Well, this was a study of cognitive, studies that looked at cognitive, behavioral, and quality of life issues. And when you get your printouts, you can see that there's a theme that runs through these. First of all, this effect size over here, that just means there's a pretty good chance that the measure that we took at the beginning and the measure we took at the end are accurate, and the one that we took at the end that showed there was some improvement, we can trust it to some degree. That's what I said, Nancy, about numbers. There's a story behind these numbers. But I want you to pay attention to what's hidden in this middle part here, the essential characteristics. Okay, so here's cognitive training. Group sessions, okay? Cognitive stimulation, group sessions. Multi-component enriched group cognitive stimulation. All right, are we seeing a theme here? Okay, down here, multi-component for persons with dementia and their care partners. All right, that we can improve quality of life by continuous counseling and support. You and I were talking about that a little bit before. We can do this. This is good research that shows that this can be done. And do you see the social element that runs throughout these studies? Here's another one. This is a white paper that came out in the response to the national plan in the United States. 44 randomized controlled trials, the so-called gold standard of all research, looked at psychosocial treatments. Okay, most of these treatments have been developed for care partners. Okay, most of the psychosocial treatments have been for support groups, right? Those of you who run support groups, that's what has been studied the most. Is if you take care of the care partner, you're taking care of the person with dementia, right? It's a good thing. And we need more research for people in the early and late stages, and people under 65 and people with other kinds of dementias, right? So this was a study. I'm going to show you our national plan in a little bit. This was a study that was dictated by the national plan that Congress passed and the president signed in 2011. And if you read all through it in fine print, it says you need to go gather the evidence about the psychosocial treatments. And so that's why they put this white paper together. And sure enough, it finds that there are some out there that are effective. Some of these structured support groups, for example, they are effective. So, dementia studies is an enormous field. It's a field that includes the basic biological sciences that are trying to figure out, why are these plaques and tangles forming in the brain, and what are the genetic bases of this, and all those kinds of questions. What's the role of toxic chemicals, et cetera, et cetera. And then we've got clinical medicine and all that related fields. How do you diagnose? How do you treat? How do you care for people? A huge area. The social sciences, that's my field. You know, the psychologists, the sociologists, the anthropologists, the economists, you know, the dreary science. They're the ones that talk about sometimes bankrupting society. The arts and humanities. It's very important to me to get that up there because the humanities, of course, can include philosophy and theology and religious studies, right? And the arts, and I'm going to talk about the arts later on. And then these applied fields. We need people, we need the MBAs of the world who do organizational policy to help us figure out what's the best way to bring services to families who are dealing with dementia. And, okay, so it's complicated, isn't it? It's a growth field for, if you know any college students these days, tell them to go into dementia studies. So I said I was going to say a few words about public policy. This is, as I said, one of the three legs of the stool, research, practice, policy, okay? And we all have to pay attention to this. This is the National Plan to Address Alzheimer's Disease. I just wanted to show a comparison for you. This is in the United States. This is the one in England. John and I get a lot of our good ideas from England. This is their national strategy in England. Living well with dementia. And I love this down here. Putting people first. A little bit different, isn't it?
Yeah, back up.
Yeah, back up.
Yeah. So if you have a dementia that is not Alzheimer's disease, what is this saying to you?
Right. It says you don't count. Well, actually, what it says what it says in the
worse.
It gets worse. In this, our national plan, signed by the president and passed by Congress. Amazing, they got bipartisan support to pass this. What it says in this document is that we are going to use the word Alzheimer's in this document, but by Alzheimer's we mean all the other dementias too. And so,
which are radically different, present different challenges.
You know, right. And so I see the face of that woman and her husband who talked to me, and they felt like they didn't belong. And this is our national plan, and they may feel like they don't belong. And this is England, living well with dementia, national dementia strategy, putting people first. So, two different stories. United States and United Kingdom. The vision in the United States, again, you'll get these slides, is to eliminate the burden of Alzheimer's disease. So there you've got it, the language again. That's the goal, is to eliminate the burden, or the vision rather. And these are the 5 goals. We're going to prevent it by 2025.
Yay for us.
Yeah.
Yeah, that's just right around the corner. Right. Okay? Optimize care quality and efficiency, yes. Efficiency worries me a little bit because I hear robots when I see that, but anyway. Expand supports, I'm all in favor of that, but then I worry about, we've got 8 people at the Alzheimer's Association to cover 53 counties. Enhance public awareness, hooray, must do that, except why are we calling it just Alzheimer's disease? And track progress and drive improvements. That's the quality indicators business that you're all so familiar with. All right, here's the United Kingdom. Their vision is to improve the quality of life for people with dementia and their carers. And these are their goals. Remove the stigma, make sure people are properly diagnosed, and develop a range of services. And I love this part here, that meets the changing needs of persons diagnosed and their cares over time. I love that. It's progressive. And I worry a little bit that we're coming up with all these whiz-bang fabulous programs for people in the early stages because those are the noisy baby boomers, right? And they're great programs. But what are we doing for the 85-year-olds who have progressed further, who have lost the language? who may no longer be ambulatory, who need all kinds of supportive care. Their needs have changed. And are we going to pay attention to them? I hope so. And I just love the fact that in the United Kingdom's national strategy, they acknowledge these changing needs of the people with the diagnosis. This is too small for you to read, but just to point out a couple of things. Being diagnosed early, you'll get the handout on this. This is by 2014, that's next year. Everybody in England should be able to say this. I love this. I can enjoy life. So in their national strategy, they say, if you've got dementia, you should still be able to enjoy life. And that's what a dementia-friendly community can enable you to do. And we'll give you more details about that later. And then to your point about palliative care, I think this is really, really important. I am confident my end-of-life wishes will be respected. I can expect a good death. This is right in their national strategy. Now, you all remember what happened when the Affordable Care Act tried to introduce one discussion between a patient and a doctor about end-of-life wishes, right? Death penalties. That's what we got. So, my last slide, and then you all get a break. Why do we need this new story? That's what we're all about here today. We're here to tell a new story. Okay? We've got that line, on the longevity revolution that goes from 1900 up to whatever. We got the pig and the python. We need a new story that is not about fear. We need this new story because people are terrified, and because this fear plus lack of knowledge produces stigma and broken relationships. Because we're so terrified, and we move away from relationships.